Welcome everyone. In this video we shall be talking about myocardial infarction and discuss most of the important questions related to it. So moving on to the first question. A 55-year-old male presents with sudden death 2 hours after a marathon. The post-mortem examination of the heart is being performed. Which of the following histopathological changes is most likely to be observed at this stage of myocardial infarction? Okay. So we need to know about the histopathological changes in MI. So before we read the options, let's have a look into the histopathological changes. The histological changes in MI. So it is extremely time dependent, right? So remember that from 0 to 30 minutes, there are no histopathological changes. We only get electron microscopy changes. In the form of three things. Number one is myofiber relaxation. Then we have glycogen loss. And finally, we have mitochondrial swelling. These are all electron microscopy findings which can be seen in this time span within 0 to 30 minutes. Okay. Now, after 30 minutes, from 30 minutes to 4 hours, now the histopathological changes appears. The first change is waviness of fibers. Along with something called the contraction band. This is the earliest histopathological change. Okay. Then from 4 to 12 hours, the early coagulative necrosis sets in. Okay. Then from 12 to 24 hours, there is increase in coagulative necrosis. And early neutrophilic infiltration starts, and the early neutrophil infiltration starts. Okay. Now from day 1 to day 3, this necrosis increases to a peak, and also the neutrophils also increases. Okay. Now from day 3 to day 7, now the neutrophilic infiltration starts to decrease and is being replaced by macrophages. There is increase in macrophages, which will cause phagocytosis, of the dead cells, of the dead neutrophils as well as the dead tissue. Okay. Now from day 7 to day 10, there is early granulation tissue formation. Along with that, we get neovascularization. From day 7 to day 10. Okay. Now day 10 to day 14, there is increase in collagen deposition. The process of fibrosis starts. And finally, from 2 weeks to beyond 8 weeks, scar formation occurs. Finally. Okay. Now let's move on to the option. Right, it is at 2 hours. So at 2 hours, so that is between 30 minutes and 4 hours, we would get wavy fibers with contraction bands. Okay. The granulation tissue with neovascularization would be seen on day 7 to day 10. Extensive coagulative necrosis and neutrophilic infiltrate from day 1 to day 3, and macrophage infiltration from day 3 to day 7. Okay, so the answer over here would be D. Moving on to the next question. A 62-year-old patient presents to the ER with chest pain lasting for 3 hours. Troponin I is elevated. Which of the following biochemical markers would be most specific for detecting a reinfarction if the patient develops new chest pain 4 days later? Okay. Now, we all know that this troponin I is the most sensitive and the most specific cardiac biomarker, but that is for the first acute episode. That is for the first episode, right? Not for a reinfarction. Okay. Extremely sorry for the cut, right? So we need to know the cardiac biomarker for reinfarction. Remember that the concept behind is that for reinfarction we need a cardiac biomarker that will reach its peak and will again drop to its normal levels very quickly, right? Among the given options, myoglobin is the earliest marker to rise and the earliest marker to fall, but there is a problem. This myoglobin is the earliest to fall, is the earliest to rise, earliest to fall, but it is extremely non-specific. It is extremely non-specific, right? It rises, peaks and then falls within 24 hours. But myoglobin is extremely non-specific. Even for skeletal muscle injury, we would get a rise in myoglobin. LDH, again, it is non-specific. Again, it is non-specific and is obsolete. That's why it is obsolete. Right, then we have the CKMB. The CKMB is the perfect marker for reinfarction. It is the perfect marker for reinfarction because it returns to normal within 24 to 48 hours. Within 24 to 48 hours. So it rises, then it falls within 24 to 48 hours. By 48 hours, it has reached its normal level. Now after 4 days, again there is a reinfarction, right? So it will increase again. So this will give us a good idea about reinfarction. But if we talk about these troponins, right? Remember that trop T takes around 10 to 14 days, 10 to 14 days to return to normal. Whereas trop I takes around 7 to 10 days. Okay. Now, so after 4 days, now first episode has occurred. The levels have started to rise. They have peaked after 2 days. They have peaked after 2 to 3 days. Now on day 4, they are decreasing, but they are still high. On day 4, they are increasing, but they are still high. So on day 4, you would get an increased troponin I and troponin T values, but you cannot differentiate between whether it was the first episode that is responsible for the rise or whether it is the reinfarction. Okay, that's why they are not very good markers of reinfarction. They are not very good markers of reinfarction. Okay, so the marker of reinfarction would be the one that would decrease very early. Myoglobin does decrease the earliest, but myoglobin is non-specific. That's why CKMB would be the perfect choice over here. Okay. Moving on to the next question. Now, a 62-year-old patient presents to the emergency with chest pain. Now, he is hypotensive and has clear lung fields. Okay. An ECG is done, which is shown in the image below. What is the most likely culprit artery and the immediate management priority? Okay. So, we have a ECG over here. From the ECG, we need to find which artery is involved, right? Now before we do this, let's have a basic idea how to decipher which type of MI, to decipher the type of MI using an ECG. So before that, let's have a look into the ECG leads, how the ECG leads look into the heart. So if this is the heart, remember that lead 1 is looking from over here, right? Let's move this a bit below. Right. So this is the heart. Lead 1 is looking from over here, right? That is from the left side. Straight, horizontal, the horizontal plane. Okay. Lead 2 will look from over here, making an angle of 60 degree. Then we have lead AVF from the foot, from below. So this is 30 degree. This is lead 3. Again making an angle of 30 degree. Over here we have lead AVL looking from the left side, left upper hand, right? 30 degree. And we have this AVR, right, which makes an angle of 30 degree from the horizontal. So these are the limb leads. This is how vertically the heart is being looked. Now if we talk about the chest leads, suppose this is the cross section. of the heart. Okay. So this is the this is the left ventricle, this is the right ventricle. So over here V1 and V2 looks at the right ventricle. At the septum we have V3 and V4, and finally at the left ventricle we have V5 and V6. So we all know which leads point towards which aspect of the heart. Okay. Now let's have a look into a table, right? Let's have a look into the ST segment changes, right, that occurs, right? Let's have a look into the ST segment changes in different types of MI. Okay. So for that, right, always remember that there are two types of changes seen in an MI, right? There is an ST elevation at the location where there is infarction, and similarly on the opposite side of the heart we will get an ST depression as a reciprocal change. Okay. So let's first have a look into the anterior MI. Anterior MI means the anterior wall is involved. What are the leads that are looking at the anterior wall? These chest leads are looking at the anterior wall. So there would be ST elevation from V2 to V5. Okay. So we would get similar reciprocal change, that is ST depression on the opposite side. What is the opposite side to anterior? Posterior side. See, we do not have any leads in the standard 12 lead ECG which looks into the posterior aspect of the heart. So we won't get any reciprocal ST segment depression. Okay. Then we have inferior wall. MI. What are the leads that are looking at the inferior wall? This 2, 3 and AVF are looking for the heart from below. So we would get ST segment elevation from 2, 3 and AVF. And we would get ST segment depression on the opposite side, the ones that are looking from above, right? So we would get ST segment depression in AVL because AVL is looking from above, right? Sometimes we can even get for 1. And sometimes we also get from V1 and V2 because V1 and V2 are looking the heart like this, V1 and V2 from the right side. So for V1 and V2 also we can get changes. Okay. Then comes the lateral wall MI. Lateral wall MI, what happens? See, AV1 and AVL are looking from the lateral aspect. So we have 1 and AVL, and from the chest leads this V5 and V6 are looking from the lateral aspect. V5 and V6 are looking from the lateral aspect. So V5 and V6. So we would get ST segment elevation. Okay. Similarly, ST segment depression to the opposite side. See, you can very well appreciate. See, these are the opposite ones. AVL ke opposite mein we have lead 3. Okay. So we would get in lateral here we have 3 and AVF would have ST segment depression, right? Yeah, and for limb leads we would, and for chest leads V1 and V2 can also show ST segment depression. Okay. And finally we have the posterior wall MI. In the posterior wall MI, see, we have no leads which are directly pointing towards the posterior wall. So again ST segment elevation would be absent. But we can get reciprocal changes. Where we would get the reciprocal changes? On the opposite side, that is on the anterior aspect. So on V1 to V3 leads we would get ST segment depression. Okay. So this table is the most important table, right, in this topic. Okay. How to differentiate different kinds of MI. From an ECG. Now let's have a look into the ECG. So over here we have this ST segment elevation in lead 2. We have ST segment elevation in lead 3. We have ST segment elevation in lead AVF. Okay. Besides that, we have ST segment depression in AVL. We have ST segment depression in lead V1. We have ST segment elevation in lead V2. Although we do not have any ST segment depression over here in V1, but we have got enough information to mark it as inferior wall MI. We have got enough information to mark it as inferior wall MI because we all know that 2, 3 and AVF, ST segment elevation, AVL 1, V1, V2, we would get ST segment depression. Everything is present over here except the ST depression in lead 1. Okay. Now inferior wall is supplied by RCA, right coronary artery in 85% of the cases, and is supplied by the left circumflex in 15% of the cases. And the question asks us about the most likely culprit artery, so we would mark right coronary artery. Okay. So we can easily rule out A and D. But the question also asks us about the immediate management priority. Now we have seen that there is hypotension and there is clear lung fields. Now something important to know about the pathology in this case, is that there is right ventricular involvement. There is only right ventricular involvement. Okay. As a result of which the right ventricle is not contracting, so it cannot pump the blood into the lungs and then into the left ventricle. So there would be decreased blood to lungs. And left ventricle, right? So technically we have a situation of a decreased preload, right? And in order to manage this condition, we need to increase the preload, and we can increase it by providing IV fluids. Okay. And if you look into the all other options, nitroglycerin, morphine and diuretics, all three of them decrease preload. So they will just worsen the condition. Okay. So the answer over here would be C, right coronary artery and IV fluid bolus as immediate management. Okay. So this table is the most important thing that we need to remember from this topic. Okay. Now we move on to the next question. Now a patient with a known history of posterior wall MI would typically show which are the following reciprocal changes on a standard 12 lead ECG. Okay. Remember that we all know that we get ST segment depression in V1 to V3, right? We have read that. So answer would be option D, ST segment depression and tall R waves. Now another component is tall R waves. So we all know that this ST segment depression is a reciprocal change, to what? To ST elevation. Okay. And this tall R waves are actually reciprocal changes to deep Q waves. Now remember that, as we know that ST segment elevation is a marker of myocardial infarction. Similarly, deep Q waves are also markers of myocardial infarction, although they are much less specific than that of ST segment elevation. Okay. If we look into the previous ECG, you can very well appreciate that there is a there is depression of Q waves. We get deep Q waves over here, not depression of Q waves, deep Q waves. And similarly, we have peaking R waves. In lead 1 and lead AVL in the reciprocal leads. Okay. So these are also signs of myocardial infarction, though less specific than ST segment elevation and depression respectively. Okay. So D should be a correct answer. Another important thing that I want to mark over here is that this thing, ST segment elevation in V7 to V9. Yes, V7 to V9 are the posterior leads. We would get ST segment elevation in V7 to V9, but these V7 to V9 are not a part of a standard 12 lead ECG which have been asked. Okay. This V7 to 9 are extra leads. Okay. Pathological Q waves in 2, 3 and AVF, these are signs of inferior wall MI. 2, 3 and AVF looks the heart from below, inferior wall MI. And elevation in 1 and AVL, again this is lateral wall MI, Okay. Everything can be solved, right? That not everything, right? The detection of ECG, detection of the type of MI from ECG can be solved using this table. Okay. Now moving on to the next question. Now a 48-year-old male presents with STMI. Okay. He is at a non-PCI capable center. The nearest PCI center is 3 hours away. Excuse me. What is the most appropriate management according to the ACC or AHA guidelines? Now, before we look into it, let's have a look into the management of STMI. Right. Management of STMI is divided into 2 parts on the basis of whether PCI facility is available or not. If PCI facility is available, and that too within 2 hours, or 120 minutes or 2 hours, then we will go for primary PCI. But if it is not available, then we would go for immediate fibrinolysis. Right? Of course, if there are no contraindications, along with that we would give adjuvant management. Adjuvant management includes our dual antiplatelet therapy plus anticoagulants. We might add anticoagulants. Then we have statins, right? These are our adjuvant management. But the most important thing is immediate fibrinolysis if there are no contraindications. Okay. Now let's have a look into the question. Now the patient is in a non-PCI capable and the PCI capable center is 3 hours away. So what should be our next step? It should be immediate fibrinolysis. Wait for troponin results before deciding. No, troponin results do not have much of a role are not required if we get an ST segment elevation. If we get an ST segment elevation, then troponins are not even required. Okay. Administer clopidogrel, aspirin and clopidogrel and observe. See, we would administer aspirin and clopidogrel, but we won't observe, right? Aspirin and clopidogrel do not reperfuse the lesion, do not reperfuse the heart. Okay. Transfer to PCI center regardless of time? No, not regardless of time. It should have to be done within 2 hours, right? If we cannot do that, then we have to fibrinolysis. We have to go for fibrinolysis. Okay. So answer over here would be B. Okay. Moving on to the next question. Right. Now, 4 days after an extensive anterior wall MI, a patient suddenly develops a new harsh pansystolic murmur at the left lower sternal border and rapidly deteriorating hemodynamics. What is the most likely complication, right? So now this type of questions, these questions have to be solved by ruling out options. So let's start. First we have Dressler syndrome. What is Dressler syndrome? It is actually an autoimmune pericarditis. What happens that it develops weeks to months after. It is autoimmune condition. It develops weeks to months after MI, right? But over here it is just 4 days. right? And what are the clinical features? What are the clinical features that we can get? We can get fever, we would get chest pain, and the hemodynamics will be normal, right? Your murmur and the shock component, would be absent, which have been mentioned over here. So Dressler syndrome is not an answer. If we talk about this ventricular septal rupture, now this is secondary to an anterior wall MI. This is secondary to an anterior wall MI, which has been mentioned over here. Okay. And it occurs 3 to 7 days. 3 to 7 days after MI. It occurs usually 3 to 7 days after MI. What are the clinical features that we get? Over here, there is a ventricular septal rupture. Now, whenever there is a septal rupture, of course, there would be a left to right shunt. There would be a left to right shunt, right? Whenever there is a left to right shunt, first thing we would get a murmur. We would get a murmur. What sort of murmur? The murmur will be similar to that of VSD, right? The blood is shunting from left ventricle to right ventricle, so it will be a completely pansystolic. It will be completely pansystolic murmur. And where will it be heard? Similar to that of VSD, it will be heard at the left lower sternal border. Okay. Moreover, since there is a shunt, there would be increase in pulmonary blood flow and decrease in cardiac output. It would finally result in a cardiogenic shock state. So everything, we can get everything over here, right? Everything about the question has been mentioned. Everything in the question has been mentioned about this ventricular septal rupture. Okay. If we look into the other options, free wall rupture. What is free wall rupture? Free wall rupture means the blood is there is leak of blood into the pericardium, right? Free wall rupture and the blood is leaking into the pericardium and would finally lead in a cardiac tamponade Over here, yes, shock component would be present, which would be obstructive in nature, right? But the murmur would be absent. Over here. An acute mitral regurgitation, yes, in acute mitral regurgitation, which is due to rupture of papillary muscle, right? Remember that this is secondary to inferior. This is secondary to inferior wall MI. This is secondary to inferior wall MI. Over here, we would get murmur. We would get a murmur of mitral regurgitation. Mitral regurgitation ki murmur is a pansystolic murmur. But where do we get that murmur? We get that murmur in the apex and it radiates to the axilla. So the murmur description differentiates option B and option D. So our answer over here would be B. Now these type of questions have to be ruled out based on the exact description. Okay. So moving on to the next question. Which of the following is considered the most common cause of death in pre-hospital phase in acute myocardial infarction? This is a factual question. Answer is ventricular fibrillation. In the pre-hospital stage, due to the acute ischemia and the catecholamine surge, there is triggering of ventricular arrhythmias, most commonly in the form of ventricular fibrillation, sometimes even ventricular tachycardia, which can result in death in pre-hospital phase. Rupture of interventricular septum is actually a post-MI complication. Which occurs 3 to 7 days after MI, right? And this cardiogenic shock and congestive cardiac failure would be in-hospital deaths, right? Not in pre-hospital deaths. Okay. So answer over here would be option C, ventricular fibrillation. Okay. Moving on to the next question. Which of the following, match the following post-MI complications with their characteristic timing, right? So fibrinous pericarditis is actually due to a direct inflammation which is triggered by the necrotic myocardium. So necrosis of the myocardium starts within 1 to 3 days. The necrosis is extensive and there is neutrophilic infiltration. So, and since that inflammation is only causing fibrinous pericarditis, so that must occur within 1 to 3 days. Okay. Ventricular aneurysm. This ventricular aneurysm is actually secondary to scar formation. Right? Once the scar is formed, there is a thinned out tissue which will bulge out due to systole. And the scar formation requires more than 8 weeks. More than 2 months. So, ventricular aneurysm, it would be months later. Then comes papillary muscle rupture. This papillary muscle rupture, remember that this is seen in, as we have read, in inferior wall MI, and this is secondary to the clearing of the cells. This is secondary to clearing of necrosis and cells by macrophages. right? As a result of this clearing the involved tissue by macrophages, that would result in rupture of the papillary muscle. Okay, and this clearing occurs from day 3 to day 7, right? We have read that in the first question. So papillary muscle rupture, our answer should be day 3, day 2 to day 7, or day 3 to day 7, whatever. And Dressler syndrome as an autoimmune etiology, and would take weeks to months time, right? So should be C. 1A, 2D, 3B, 4C. So option A should be our answer. Okay, just with the pathology, just with the pathophysiology, we can decipher the time. Okay. Moving on to the next question. Now we got a similar question, right? A 70-year-old female with a history of hypertension presents with vague epigastric pain and vomiting. Her ECG is shown. In the image below. Which coronary artery is most likely occluded? So we would use that table, right? We get ST segment elevation in lead 1. Okay. Then we have ST segment depression in lead 3. Then we have ST segment elevation in AVL. Okay. Then we have ST segment depression in lead AVF. Then we have ST segment depression in lead V1, ST segment depression in lead V2, and some amount of depression in V3 as well. So this suggests us of a lateral wall MI, right? As we all know, if we have a look into this table once again, 1 and AVL ST elevation, right, and ST depression in 3 and AVF 3, AVF V1, V2, right? This is suggestive of lateral wall MI. Okay, so over here the diagnosis becomes lateral wall MI. So we can easily identify using an ECG just with the help of that table. Okay. Now the question is which coronary artery is involved, right? So which artery supplies the lateral wall? It is the left circumflex. Remember, left anterior descending supplies the anterior wall. This the lateral wall. Right coronary artery supplies the inferior wall. Posterior descending supplies the posterior wall. Okay. So answer would be B. So moving on to the next question. Now, in the management of NSTMI, which of the following scores is most commonly used to decide between an early invasive strategy versus a conservative ischemia guided strategy? It is again a factual question. It is Gray score, right? Remember that the CHA to DS2 VASC score is for atrial fibrillation. Glasgow Coma score is for level of consciousness, right? And Wells criteria is for pulmonary embolism. Okay. Now Gray score is a very complicated score. Just remember the values. The interpretation of Gray score. If the value is more than 140, it is a high risk condition, and we would go for early invasive therapy. What is meant by early invasive therapy? Within 24 hours. It has to be done within 24 hours. Okay. If the score is between 109 to 140, it is an intermediate risk. So we would go for a delayed but invasive procedure. Delayed but invasive therapy. What is meant by delayed? Within 72 hours. Okay. And if the score is less than 109, it is low risk. So we would go for conservative management, right? With conservative medical management. But this is the importance of Gray score. Quite a complicated score, requires biochemical parameters and a lot of things. Okay. So this is the most important. This is the interpretation of Gray score. Okay. Moving on to the next question. Now, a 65-year-old male with a history of asthma and STMI is being started on medical therapy. Which of the following beta blockers is the most appropriate choice to minimize the risk of bronchospasm while providing cardio protection? So remember, what is the role of beta blockers? In NSTMI? We need to decrease the heart rate, and once we decrease the heart rate, there will be decrease in the myocardial oxygen demand. And the myocardial heart rate, in order to decrease the heart rate, we need to block the B1 receptors. And since the patient has a history of asthma, we do not want this beta 2 blockade, right? Beta 2 should be contraindicated. So we need selective beta 1 blockers or second generation beta blockers for this condition, of which esmolol is the only answer, right? Now remember that esmolol is a better choice than metoprolol. Metoprolol is also a beta 1 selective answer. Although metoprolol is not there in option, but had they been both metoprolol and esmolol, our answer would have been esmolol. Why? Because esmolol is ultra short acting. Why? Because it is metabolized by RBC esterases. Okay. And That's why it is better than metoprolol, because some amount of beta 2 activation would be there, and since it if there is if esmolol or metoprolol triggers some amount of asthma or mild bronchospasm, then esmolol being ultra short acting, within 8 to 9 minutes the action will be over, so it is considered better than metoprolol. Okay. If we talk about the other ones, these are all non-selective. Carvedilol is actually a third generation beta blockers which blocks beta 1, beta 2 as well as alpha 1. Right. Okay. So option D should be our answer. Moving on to the next question. Now, regarding the TIMI risk score for NSTMI, which of the following parameters are not included in the calculation? Now, this TIMI score, although it is not better than Grace, but this TIMI score, also known as thrombolysis in MI score, is a bedside test. It is a bedside test, right? And we consider 7 parameters. Over here. What are the 7 parameters? Number 1 is age more than equal to 65 years. Then more than equal to 3 CAD risk factors. What is meant by CAD risk factors? Like hypertension, like diabetes, like smoking, dyslipidemia, and a lot of other risk factors, right? All the things that can lead to coronary artery disease. Then we have known coronary artery disease. What is meant by known coronary artery disease? More than equal to 50% of coronary stenosis. Okay. Then we have ST segment changes. ST segment deviation on ECG. Right. Fifth parameter is more than equal to 2 angina episodes in last 24 hours. Okay. Then we have increased cardiac biomarkers. And finally, aspirin use. We have aspirin use in last 7 days. These are the 7 parameters. All of them can be done within seconds. All of them can be done just with history or examination, or even bedside tests, right? Okay, we do not need invasive or biochemical tests for that. Okay. So let's have a look into the options. Yes, option A should be our answer. We do not check for left ventricular ejection fraction. Okay. Now what is the, if we talk about the TIMI score key interpretation, right, it would be similar to that of Grace. If the score is 0 to 2, it is low risk, we would go for medical management. If it is 3 or 4, it is intermediate risk, so we would go for delayed invasive procedure within 72 hours. If it is 5 to 7, it is high risk, we would go for early invasive management within 24 hours. Okay. But remember the fact that Grace is superior to TIMI. But TIMI is a bedside test. We can do it quickly. Okay. Moving on to the next question. A patient 2 months post MI presents with persistent ST segment elevation in the same leads as the original infarct, despite being asymptomatic. And an echocardiogram is ordered. What is the most likely finding? Remember that this is a very characteristic presentation. Of this persistently elevated ST segment, right, on the same leads as the original infarct, but the patient is asymptomatic. It is ventricular aneurysm. First of all, it is after 2 months, and this persistently elevated is due to the thin scarred myometrium, right, which causes a dyskinetic bulging, dyskinetic outward bulge. There is a dyskinetic, outward bulge on systole. Whenever since the myocardium is thinned out, so whenever there is a systole, that would push that part out, leading to formation of this ventricular aneurysm. Okay. So acute pericarditis, over here we would get diffuse ST segment elevation. And symptoms would be present. In the form of chest pain. Pseudoaneurysm, it is seen in a contained free wall. Rupture. Right. Okay. Over here the ST segment won't be elevated, right? There won't be any elevation of ST segment, right? Okay. And reinfarction, again in reinfarction symptoms would be present. Cardiac biomarkers would be elevated. Okay. So just remember that this is a very characteristic presentation of ventricular aneurysm. After months there is persistently elevated ST segment elevation without any symptoms. Okay. Moving on to the next question. A 50-year-old female with an acute STMI is being prepared for fibrinolysis. Which of the following is an absolute contraindication to fibrinolytic therapy? Right. This is a very important part. We need to know the absolute and the relative contraindications to fibrinolysis. Before we answer this question, let's have a look into the list. What are the absolute contraindications? Number 1 is prior intracranial hemorrhage. Number 2 is ischemic stroke within 3 months. Ischemic stroke within 3 months. Right. Then we have any intracranial neoplasm or an arteriovenous malformation. Okay. Then we have suspected aortic dissection. We would not go for fibrinolysis. If there is any active internal bleed. Okay. Then we have closed head or facial trauma within 3 months. Right. And we got major surgery or a prolonged CPR within 3 weeks. These are the absolute contraindications. Now if we have a look into the options, ischemic stroke in 2 months, yes, it has to be within 3 months. It is an absolute contraindication. So this should be our answer. Remaining all 3 are relative contraindications. So now let's have a look into the relative contraindications to fibrinolysis. Number 1 is poorly controlled hypertension. Right? Right on presentation, the value is the BP is more than 180 by 110. Then again ischemic stroke, but this time more than 3 months ago. Pregnancy is a contraindication. Then we have active peptic ulcer. Peptic ulcer is a relative contraindication. Use of anticoagulants is a relative contraindication. Dementia in a patient is also a relative contraindication. And recent internal bleed within 2 weeks. Sometimes even 4 weeks is considered. Okay. But not active. Active bleed is an absolute contraindication. Okay. So we need to know the absolute and the relative contraindications. Okay. Moving on to the next question. Which of the following describes the no reflow phenomenon observed during primary PCI? This is something which I didn't know, right? While forming these questions, I came to know about this concept, so I put that question over here. Remember that this no reflow phenomenon is this failure of myocardial tissue perfusion despite reopening of the epicardial coronary artery. We went for a primary PCI, we opened the epicardial coronary artery, but there is no reperfusion. Now, why it can occur? This usually occurs due to microvascular embolism and capillary plugging by the neutrophils. And some amount of reperfusion injury might also play a role, but the first two are the important causes, right? And how do we manage this? We manage this with intracoronary adenosine. We manage this way, intracoronary adenosine plus minus we can go for thrombus aspiration. Okay. So moving on to the next question. So we got a patient with a recent inferior wall MI develops a sudden shortness of breath. Physical examination reveals a loud holosystolic murmur at the apex radiating to the axilla, which structure is most likely ruptured. Now this time we all know that the diagnosis is mitral regurgitation secondary to an inferior wall MI. But there's a problem over here. The problem is that we have two papillary muscles. You all know that it is due to rupture of papillary muscles, but which one? You can easily rule out B and C, but which one? Remember that this anterolateral papillary muscle has a dual blood supply. It is supplied by both LAD and LCX. Right, that's why it is very rare to get ruptured. Whereas this posteromedial supplied by the right coronary artery only. And we all know that inferior wall MI is due to compromise of the right coronary artery. So our answer would be over here A, posteromedial papillary muscle. Okay. Moving on to the next question. In the context of MI management, what is the primary mechanism by which nitroglycerin reduces myocardial oxygen demand? We all know that nitroglycerin causes venodilatation, right? Venodilatation, which would result in decreased venous return or decreased preload, right? Decreased preload. Our answer should be option C. Venodilation leading to decreased preload. What happens with that? There is a decrease in left ventricular end diastolic volume, right? And decrease in end diastolic volume would result in a decrease in wall stress. This decrease in wall stress is very much helpful. Right? In this condition and in MI. Okay. So the answer over here should be option C. Okay. Moving on to the next question. Now, which of the following is the early invasive strategy? Early invasive strategy window for high risk NSTMI patient, right? We have discussed this. This is within 24 hours, right? Remember that the invasive strategy in NSTMI can be divided into 3 categories, right? Number 1 is early, which has to be done within 24 hours, and when to do when the grace score is more than 140 or a TIMI score of more than equal to 5. And then we have a delayed version, which has to be done within 72 hours. It is done when the grace score is between 109 to 140, or when the TIMI score is between 3 to 4. Okay. And there is another category which is known as the immediate invasion, right? That is to be done within 2 hours. When is this done? This is done in refractory chest pain and associated compromised vitals right? Okay. In a hemodynamically, if the patient is the hemodynamically unstable patient with refractory chest pain, we would immediately go for invasive strategy. Okay. Moving on to the next question. A patient is diagnosed with silent myocardial infarction. This presentation is most classically associated with which of the following conditions? Now, silent myocardial infarction is nothing but MI without pain. It is MI without pain, right? What happens? This pain, why? Because the pain fibers are destroyed. The pain fibers are involved. The pain fibers are destroyed, and this happens in diabetes mellitus, right? This is due to autonomic neuropathy. Right, due to autonomic neuropathy, right? The pain fibers are destroyed, so we won't get the pain sensation, right? But there would be destruction of the myocardial muscles, right? And finally, so that would lead to a silent myocardial infarction resulting in a sudden death. Okay. Moving on to the next question. Following a large MI, a patient develops ventricular remodeling. Which class of drugs is specifically indicated to inhibit this process and improve the long-term survival? Remember that this ventricular remodeling is done via this RAS pathway, right? Everything, right? Angiotensin, aldosterone, everything, right? All the components, renin, angiotensin, aldosterone, all the components are responsible for this myocardial hypertrophy, myocardial hypertrophy, as well as fibroblast activation, resulting in fibrosis of the myocardial tissues. That is our ventricular remodeling. So in order to stop that, we need to stop this RAS pathway. And how do we do that? Anything which can stop the RAS pathway would be beneficial over here. So the answer over here would be BAC inhibitors, because they do stop the RAS pathway. So the drugs that inhibit ventricular remodeling include AC inhibitors. We have AC inhibitors. We got ARBs. Besides that, we have selective beta 1 blockers, because they inhibit the renin release, from the JG cells. Renin release from the JG cells. And we also have mineralocorticoid receptor antagonists like spironolactone. Right, this is going to inhibit the aldosterone component. Okay. Now, besides this RAS, there are minor pathways which can be blocked with the help of statins. Statins can also help reduce ventricular remodeling. Besides that, a drug called nicorandil can also help in inhibition. Nicorandil is a potassium channel opener. Okay. So nicorandil can also help in stopping ventricular remodeling. Now, with this question, we come to the end of our discussion on myocardial infarction. I think I have discussed most of the questions. They will be enough for NEET PG discussion. If you like this video, consider subscribing to this channel, and thank you for watching.